we've just found a whole new way to do it. The armchair way with Travels. I'm John Hemingway. Join us for a brand new season each week on Travels.
Returning to Iowa Public Television, January 13th.
Iowa Public Television.
TV worth watching. IPTV.
In its continuing commitment to bring quality health care to all Iowans, the Iowa Hospital Association is pleased to help support the Iowa broadcast of the Health Quarterly.
This year, in the United States, we will spend $750 billion to take care of our health. We will spend more money per person than any other country in the world. And yet, with the greatest medical establishment in history, something is going terribly wrong. 37 million Americans have no health insurance. 3/4 of the uninsured are families of the working poor. 1 million people a year are turned away from doctors' offices and hospitals. Our healthcare system is headed for catastrophe.
Tonight on the Health Quarterly, we retrace the journey with Robert Kennedy as America discovered the face of poverty.
When I see conditions like this, in 1991, 11 people living in 2 rooms, no running water, I see conditions beyond 1967.
And the children of drugs. Is there a better way to help?
You're willing to spend $500,000 on this baby after it's born, but you wouldn't spend $500 or $600 on it before it was born so that it could have been born healthy and not need.
And in the AIDS report, the story of a young girl and her best friend, her father.
My only wish for Christmas is for my father to be here with me. That's my only wish for Christmas. I don't need gifts. I don't need anything else.
Funding for the Health Quarterly is provided by a grant from the Robert Wood Johnson Foundation. Resources making a difference in the health care of Americans.
Good evening. I'm Hodding Carter, and this is the winter 1992 edition of the Health Quarterly. When we think of health care, we usually think of medicine, that we rely on it to work miracles, that its cost has seemed to skyrocket. And in this series, we investigate the range of problems and political solutions to the crisis. But being healthy is about more than policy options in medicine. It begins with the basics: food, clothing, and shelter. For some, even these basics are hard to afford. Although we've heard a great deal lately about the new vulnerability of the middle class, the deepest crisis in health care is not centered in the middle class. It's in a place that Robert Kennedy once called the other America. In 1967, he came to my state, Mississippi. I lived and worked there and was as skeptical as anyone else about an outsider, a Yankee, coming to see Southern poor. But when he toured the state, I went with him. What he saw, what we saw, what was there, was another America. 25 years later, we wondered if anything had changed. To find out, we decided to return to the Delta.
The Mississippi River Delta, 1967. The people here live and work on some of the richest farmland in the world. And yet, every new generation is born into the same hard life. I grew up here in the river town of Greenville, with a population of 40,000, the Delta's largest community. As a young reporter in the 1960s, I covered this territory. My family owned the town's only newspaper. Looking back, I'm reminded of just how different the times were in those days. Americans knew there were problems at home, and they wanted change. Our leaders knew it.
In a land of great wealth, families must not live in hopeless poverty.
It seems so long ago,
In
but
a
when Lyndon
land
Johnson talked about the Great Society, I did believe him.
Children just must not go hungry. In a land of healing miracles, neighbors must not suffer and die untended.
Even so, I was skeptical about the motives of the junior senator from New York, Robert Kennedy. He said he wanted to see for himself the face of poverty, hunger, and poor health across the country. A crusade, he called it. There was the trip to the hollows of Kentucky's Appalachian Mountains.
How are you? Hello.
There was his statement that he was saddened by the appalling conditions and suffering of poor Americans. His visits to Indian reservations made the nightly news. He would go to reservations in South Dakota, New York, and Idaho, where the teenage suicide rate was 100 times the national average. In the troubled Los Angeles ghetto of Watts, where the aftermath of the riots revealed that there were 10 doctors to every 25,000 people, there he was again, walking the streets, looking it over. Then, inevitably, he announced that he was coming to the poorest state in the nation. He turned up here on April 9, 1967 at the Jackson, Mississippi airport. He was traveling with other senators and a few reporters. I wasn't really sure what I thought he was doing. I mean, I wasn't sure whether he was really interested in it as a thing in itself or as a part of his own thing, which was for larger political design. Whatever Kennedy's own interest was, there were plenty of people here who knew what their own interests were. Outside agitators, we called them then. One of them was from Boston's Tufts University, Dr. Jack Geiger.
The rest of the country didn't really know what it was like to live in a shack with holes in the roof and a tin stove in the middle and dirt on the floor and a pig underneath, to drink water out of the drainage ditch, to have a sunshine privy, an outhouse that drained into the drainage ditch so that your kids had infectious diarrhea and dehydration. It was third world. They didn't have contact with the outside world to a very considerable extent, and the rest of this country didn't know about them.
When he arrived, Kennedy was briefed on the basics of poverty in the state: food, clothing, shelter, and about the people who were suffering. We followed him as he headed into the Delta along the banks of the Mississippi, stopping along the way. The scene was captured by a CBS camera crew with correspondent Daniel Shore.
We started early in the morning. It was kind of a damp morning, almost rainy as I recall it, and the whole thing was rather bleak. And he seemed to not have had enough sleep. He seemed at all, at first, uninterested, until we began coming to these sites. And then as we began to see people, you began to see him suddenly open his eyes, lose that sense that he hadn't slept enough the night before, and with some reactions, a mixture of shock and concern, suddenly begin to see conditions of poverty, and poor children, and children with worms, and people who didn't seem to have enough clothing, and these shacks and so on.
Do you have lunch?
We had lunch, yeah.
You haven't had lunch yet?
No.
And the only way I can say it as a person who was there for television is being accustomed to see senators on camera with all the necessary reactions. What I had not seen before was a senator who had all the reactions of compassion when he was off camera. It was terribly real.
What the trip really did for me was convince me that Bobby Kennedy actually was personally concerned. What I saw was a guy operating out in the field with the folk, with the kids, with the old people, with the poor, in a way which showed to me a humanity I had not recognized in him before.
It is a reflection on all of us, the fact that you have young children in the United States at the present time, with the wealthiest nation in the world, who are hungry, and their parents are hungry, is completely unsatisfactory.
What he was saying was that even here, in the worst of conditions, the government, Washington, leadership, really cares, and it's ready to say to the nation, we can't turn away from this either. At the end of his tour through many of the Delta's 18 counties, Kennedy had seen enough to make his case back in Washington. It really was a moment where the gesture of one man made Americans begin to recognize just how deep the suffering was, not only in Mississippi, but across the country. And things started to happen. Within weeks, some of the people Kennedy had seen would be eligible for food stamps for the first time. But at home, state leaders still denied that Mississippi had a problem.
We had a group of outsiders came in here and made a great national scene of how many hungry people we had. And Governor Johnson appointed a group of our own doctors. But as I recall, they reported that probably some hunger might be found in Mississippi, but not to a great extent. My thinking is that Mississippi is the best fed state in the whole nation.
The state health department, like the medical establishment in the state, the doctors and others, felt ashamed and embarrassed and defensive. Here was this misery all around them that they collectively had the responsibility for doing something about, and very clearly not enough was being done.
Dr. Geiger and others did their best, but their clinics could never meet the need. Dr. Aaron Shirley remembers.
I vividly recall one night when I was on call and 11 babies died. Diarrhea, dehydration, meningitis, pneumonia, things that babies don't die from. But by the time they got here, they had it progressed so that not much could be done. And that was routine.
Shirley and other doctors went out into the state to survey the problem.
We looked at people. We put hands on. We opened the shirts and saw, you could see the ribs through the skin, you know, the impression of the ribs, and you could see the dullness in the kids' eyes. You could see that they weren't active, you know, hot bellies, because the muscles were weak. That's what we saw.
Although official Mississippi was looking the other way, Washington was paying attention. Congress sent enough money to construct this health center in Mound Bayou, the middle of the Delta. Its mission, to care for the Delta's poor. Dr. Jack Geiger ran it.
I remember seeing mothers with children with bad infections who were terribly malnourished. And one of the things that we did early on at the health center, when we saw that, we wrote prescriptions for food, so much meat, so much milk, so much eggs, and gave them to the mothers, who took them to the grocery stores, who gave them the groceries and charged it to our pharmacy budget. But you'd look at a mother and give this prescription for food and then realize that she was going to sit there with 5 other kids who were that hungry, and you knew that they were going to share it. And it was the kind of problem that you came up against all of the time.
So with the clinic as a command post, Geiger and others would fight the battle against hunger, poverty, and poor health care for years. The people who lived in these houses wanted more for their children. It was the right time. Civil rights, the war on poverty, not since emancipation did a better life seem more possible. 25 years later, we decided it was time to return to the Delta. We went straight back to the clinic at Mound Bayou, which for so many years was the most accessible medical center for tens of thousands of people in the Delta. The health center is still in operation today, but now it's run by someone who started working here in the 60s as an aide. She came up from the fields of a plantation to get a PhD. Her name is Elsie Dorsey, and now she's the center's director.
We picked up people from the plantation and brought them in. For many of them, it was the first time they'd ever had a complete physical.
Did folks start coming, or did you have to reach out?
Oh, no. Oh, no, indeed. We had to go get people. They were afraid to come here. They were afraid not only of the white, funny-talking people from up north, but they also were afraid of the white people here.
In those days, there weren't many local black doctors, so in the beginning, white doctors from the north filled in. Now, like Elsie Dorsey, the staff is mostly from here in Bolivar County. But now it's hard to find doctors who are eager to move to rural places like the middle of the Mississippi Delta. But the need doesn't go away. What kind of load are y'all handling now?
Well, on Mondays, like yesterday, I bet we saw 75 people last night. On Mondays, you see between 200 and 275 people.
Good Lord.
On Tuesdays, you have a smaller crowd, and you have these people sitting out here, but you also have people around the corner and around that corner. So we see anywhere on any given day an average of 100, 125
well, what's your staff size? Do you have the facilities to do it?
We have the facilities. We have the facilities. We don't ever have enough people because this is rural America and it's hard. We need 3 more doctors here. We lost a physical therapist. We have not been able to replace him. We lost a radiology tech. She died a couple years ago. We've not been able to replace her.
Same thing.
So it's very difficult.
They'd rather be in a Jackson. They'd rather
be in a Jackson. They'd rather be in a Memphis. They'd rather be in...
The center owes its existence to the attention Kennedy brought at the end of the 60s. It flourished under the federal monies that came here in the 1970s. But by the end of the 1980s, the Reagan administration had cut the center's funding by 1/3. We wondered about another place that was also built precisely because of outside attention a quarter century ago. About an hour from Mound Bayou, just below Greenville, there's a community called Freedom City, where 25 years ago, new housing was built by displaced farm workers. But today, the people who stayed here call this main road the Street of Broken Dreams. The houses are falling down, and there are no jobs. Mrs. Betty Hoskins lives here with her 6 children. 5 of them have asthma. They get sick all the time, but have no money for medicine.
I have got sick many times, and they have got sick many times. And we went to their medicine, we can go and get a shot or something, but we couldn't afford to buy the medicine. I don't see it, no hope for them. And so most of them are just about right back in the same place that they began. When they came to Freedom Village, off the plantation.
This shack stands on the grounds of a cotton plantation. It's what Ms. Pearline Smith calls home, with 4 children and 6 grandchildren. The plantation's owner lets her live here for free, but there's no heat or water. Sharon Longino is the chief caseworker for Congressman Mike Espy.
Hey, Miss Pearline, how you doing? All right. I come back. Don't go. No, we won't fall, but I came back out bothering you again. Okay. Okay.
I'm going to stay here with you.
This is 11 of us and all.
All of you stay here?
Uh-huh.
And you have what, 3 rooms?
I just use these 2. It rain all in there and in there, back there.
So 11 of you stay in these 2 rooms
here?
Okay. Do you have indoor plumbing?
No.
It's very typical to find families with income of $8,000 a year and less. Families of 6 to 8 or 10. When I see conditions like this, in 1991, 11 people living in 2 rooms, no running water, no indoor plumbing. I see conditions beyond 1967.
Some of the poor people in the Delta are worse off than they were in 1967. The rest may not be worse, but there are still so many of them. Mississippi's poverty rate is twice the national average. We knew we could find out more at Dr. Aaron Shirley's clinic. He opened it 21 years ago, after Bobby Kennedy's spotlight, when anything seemed possible.
The dream come true for the poor, despite overwhelming opposition by the vast powers of the state of Mississippi.
Dr. Shirley's clinic still stands in Jackson, but so do seemingly intractable problems. Every day, blacks and increasingly whites come face to face with the tough choices that poverty and sickness force them to make.
They stay sick about 5 or 6 times out the year with bronchitis and colds and ear infections and different things like that. And I have to pinch my pennies. I really do. To buy milk, bread, just things that you need during the week. It's tough.
Once, mostly blacks came here. Now, with Mississippi's economy in its second decade of economic depression, whites are much more vulnerable.
It takes everything that my husband doesn't make that much. By the time I buy groceries and pay my bills, and if they come up sick, you know, I just have to say, okay, I'm going to take them to the doctor and let the doctor check them and then tell them I don't have the money.
Few of Mississippi's children are actually malnourished or starving, but many are undernourished. Since they didn't get a decent diet, ordinary childhood illnesses become complicated and irreversible.
These kids are dull. They don't communicate. They aren't very active. They don't learn as they should. They have chronic undernutrition that eventually leads to repeated infections, respiratory tract infections. And those chronic infections saps their strength. And over a period of time, it's going to cost society because they're not going to be productive citizens. And they're going to cost society in terms of prisons, jails.
Dr. Shirley's patients may have uncertain futures, but they are lucky to be able to have a doctor at all. It's more than you can say for many rural Mississippians.
Where you don't have facilities like the Mount Bayou Community Health Center or like the center that we have here, you see people going without until it gets to the stage where they'll end up in an emergency room.
This ambulance has traveled 90 miles. 3-year-old Rebecca Graves had to be rushed here to the University of Mississippi Medical Center because she'd been having seizures all day. She'll be here 3 days. The bill will be nearly $10,000. Her parents, Tim and Pam, can't afford it, but right now, that's the last thing they're worried about.
I don't care if I have to pay for it the rest of my life, you know. It don't matter. I imagine medical bills already done, you know, went sky high already.
Well, they had already ran all kind of tests on her with all they could do. They done a CAT scan and spinal meningitis, just all kinds of stuff, and nothing showed
Can't
up.
find anything at all wrong. I don't know what's going on.
When Dr. Shirley's patients end up in this emergency room, they become part of the statistics. Department head Dr. John Morrison realizes how big the problem is.
The infant mortality has been the worst out of all 50 states since they started keeping statistics. The reasons? It has, I think, more than its share. Again, the highest rate of unemployment, the highest rate of teenage pregnancies, the highest rate of illegitimate births, the highest rate of medical complications of any of the states.
Today, the health statistics in Mississippi are the worst in the country. But what's happened here over the past 2.5 decades has happened in every state. In the 60s, our eyes were opened. We were, as a country, ashamed of what we saw, but inspired. In the 70s, the federal government invested in food programs, social services, and public health programs. But by 1980, things had started to change.
The Reagan administration in particular cut out of the budgets. No outreach, no family health workers from the community, no environmental interventions, no food supplementation, no health education, and said, you've got to be lean, mean, and competitive, as if anybody were competing to take care of these populations. And so even the programs that have been maintained because they're of such obvious value, like Head Start or WIC, are running at much lower levels than they should be. About nearly half the women in the country who are eligible for women, infant, and children WIC supplemental food aren't getting it because the states and the federal government say they can't put up the money for it. And that's a tragedy.
Part of the explanation is that times are tighter now. But we've lost something else: public commitment and political leadership. And so, sadly enough, the future looks different from this corner of the country than it did when we heard it described 25 years ago.
There are millions of Americans living in hidden places whose faces and names we never know. But I have seen children starving in Mississippi, living without hope or future, and no one, neither industry, nor labor, nor government, has cared enough to help. These conditions will change. These children will live only if we dissent. So I dissent, and I know that you do too.
As we've just seen, the past 25 years have not been kind to the poor people of Mississippi, but certainly they are not alone. This country's 34 million poor live in every state. Most of them are neither Mississippian nor black. In every state, poverty is just one of the social problems which has fallen on the back of the healthcare system. Another such problem is illegal drugs. In our second report, we went to one place, Los Angeles, to examine some of the leading efforts to fight the relentless problem of children born addicted, after which we wondered, is there a better way to help?
Los Angeles, the largest metropolitan area in America. Illegal drugs are not new in the city's neighborhoods. About 200,000 of the country's 6 million drug abusers live here. Addiction used to be thought of as a predominantly male problem. But in 1985, things changed. They noticed in places like the Martin Luther King Hospital in Watts. Last year alone, in this one hospital, 500 babies were born exposed to drugs. Nationwide, there may be as many as 375,000 each year.
All right, she's got PCP cocaine in program 3 months.
Dr. Excelana Bean is the director of this intensive care unit. She understands that the problem of drug babies is complex, but she teaches her interns that their first responsibility is to save the babies' lives.
Why is it significant in this baby's case?
When a developing fetus is exposed to drugs in the womb, it isn't able to get enough oxygen. Nearly 30% are born premature. Some are stillborn. Some are brain damaged.
This is a baby that was born to a 35-year-old mother who had a positive history of substance abuse.
Modern medicine is successful here. Most of these fragile infants do survive. But this kind of high-tech care has a high price tag, perhaps as much as $500,000 for the hospital costs of one child. In the last 10 years, Dr. Bean has watched neonatal technology evolve.
I enjoy the challenge of taking a 1,000-gram baby and being able to keep it alive and hopefully be able to get it eventually out of the hospital. and you take this little tiny thing and it grows into a real person. And I really, really enjoy doing that, and I like it. But on the other hand, I also realize that in reality, the baby should never have been born at 2 pounds.
Dr. Bean was frustrated. She knew that the children could have been born larger and healthier if their mothers had received the proper care while they were pregnant. So on the days when she is not running the newborn's intensive care unit, Dr. Bean is downstairs, directing the hospital's clinic for women and high-risk babies.
She had no prenatal care, positive history of cocaine abuse, no alcohol, no allergies.
She says many women don't come in for care because they're afraid of being identified as drug users. But Dr. Bean encourages them. As she's watched the drug babies grow into children, she has seen firsthand the importance of early care.
Children I see who have the worst problems are children who are being brought in later in the course of the process, who receive no intervention, who are being brought back in 3, at 4, at 5, at 6, because they have problems. A large percentage of my children do well without having significant problems. A lot of them have problems, but they respond to intervention.
Intervention is a relatively new strategy. During the past 5 years, as this generation of drug babies has grown up, healthcare professionals have learned how to care for them. They now know that early and ongoing attention makes a difference. Lauren Askew works for a special program in California that is designed to help at-risk children. She makes rounds of intensive care units identifying newborns who need help. 65% of the cases she takes are children who are exposed to drugs. Once she takes on a case, she manages it for 3 years. She remembers one in particular.
I first got in contact with Elizabeth Marte when she was planning discharge for her baby.
2 years ago, Elizabeth Marte was on drugs and pregnant.
I didn't want to live. I didn't want any part of this world. But when my daughter was born, okay, for some reason when she just came out of me and I realized that my daughter was okay regardless of what I did, I looked at this as if God had given me an opportunity, another chance to start all over again.
Elizabeth's daughter, Hazel, was under Ms. Askew's care. She watched the mother and child for signs of trouble, but some problems are hard to see.
The instant she was born, I focused on her, but in my heart I was going through some guilt because there's always the thought and the doubt, you know, that haunts you, whether she still will grow up someday to be okay.
A month after Hazel was born, Elizabeth was having trouble giving her baby the attention she needed. They were homeless and living in a shelter. Because of Elizabeth's difficulties, the baby was sent to the Bienvenidos Children's Center.
During that period of time, I visited her baby, Hazel, and observed a lot of difficulties in Hazel's development. She had a lot of feeding problems. She vomited a lot. She was just very, very difficult to care for.
Ms. Askew believes Hazel's problems were not only related to drug exposure, but also due to the fact that while she was separated from her mother, several different people took care of her.
I knew that eventually I would go back and have my daughter back. And I was determined, no matter what I had to do or go through in order to get custody of her, I was going to do that. And that's exactly what I did. I did everything.
Elizabeth decided to begin drug treatment. Then, with Ms. Askew's help, she found a place to live. After 4 months of separation from Hazel, Elizabeth went to court to regain custody of her and won. And Hazel began to improve.
Hazel's development is looking very much where it should be. She's showing us expected developmental milestones.
Lauren Askew says that Elizabeth and Hazel's case is unusual because once a mother loses a child to the foster care system, it's rare that she gets her back so quickly. And a full 50% of the children are not returned to their mothers at all.
Hi, Robert.
Like Robert, a 3-year-old whose mother took heroin and other drugs while she was pregnant. She continued to use drugs after she gave birth, so Robert was put in a group home, which was where Diane and Charles Thorington met him.
As foster parents, you get a phone call, and the next thing you know, you have a child in your home. Robert was with his mother for 2 months. And at 8 months old, Robert came to live with us. In the beginning, Robert would stare off into space, and he didn't speak very well, and so we were worried about where he was going to go, what would happen to him in his life, and how that would affect him and us as a family. And
Concerned about delays in Robert's development, the Thoringtons put him into a private, non-profit nursery for children with development problems.
6 sides. 6 sides.
Robert was 20 months when he came, and he was very delayed. There was absolutely no speech other than mama.
Mary Lou Connor is the director of the West Side Children's Center.
Robert lived in his own little world, and he would just disappear. I mean, you could hardly get his attention. And because he was interested in trucks, he always wanted to carry a little truck or a car, we started with that. We expanded that to using trucks with other things. So we got books involved. We taught him how to use blocks. So we incorporated his interest into all the various parts of the program.
This kind of focused attention costs $23,000 per year per child. Of the hundreds of thousands of children who might benefit, there's only room for a few. But they work. Within 18 months, Robert was no longer behind.
Water, good for you.
If we had gotten Robert a year later, it would have been much more difficult for him to learn how to speak. I think he would have been diagnosed as retarded. He's certainly a normal child, and he wouldn't be able to lead the life of a normal child if he hadn't had intervention.
Today, Robert is keeping up with the other children in a normal preschool class, and his environment has stabilized. After a year of caring for him as foster parents, Diane and Charles were able to formally adopt him.
a lot of people would have said no to Robert in the beginning if they had been told he's 8 months old, he doesn't speak, we don't know if he'll speak, he's a drug baby, and we don't know what his future is. A lot of people would have said no, and we're thrilled. We said yes.
But at Children's Institute International, the group home Robert was in before he was placed with the Thoringtons, some of the children are less fortunate. By the time they get here, many have already lived with several different families.
Well, many of the children that we see here have had 3, 4, 5, 6 placements by the time they're a year of age. And that's really has long-term ramifications for them.
Steve Ambrose is a clinical psychologist who's worked at the Institute for the past 10 years.
In my view, the multiple placements that children go through is more damaging to them than the prenatal drug exposure that gets them into the system in the first place. The child goes from one home to the next, to the next, to the next. It becomes increasingly difficult for that child to form attachments, to have trust that people are going to be there for them. In time, that capacity is really damaged. I think if you look in our jails and prisons, you'll find lots and lots of folks who've had those experiences of being bounced around from one place to another, not having a consistent primary caregiver.
CII is proud of the fact that it can help children, but its services cost $48,000 a year for each child, another effective but prohibitively expensive program. Experts say help is needed on a much larger scale. Some are looking to a 27-year-old federal program, one already in place, Head Start. By the late 1980s, children who had been exposed to drugs were already appearing in Head Start classes for 3 to 5-year-olds. In Los Angeles, Head Start has its first program for drug-exposed children.
This is a new area for Head Start, working with children from birth to age 3, specifically children who were born drug exposed.
Hannah Hamilton is the program's coordinator.
Oh, look at Mario.
We're just now beginning to realize the impact of what we're dealing with. The children need early intervention services as soon as possible. Otherwise, at age 3, when they come into the regular Head Start classroom, you're still dealing with those unresolved issues. And there's some things with the child's development that needs to be addressed at that moment.
Nationally, Head Start is run by the Department of Health and Human Services. Dr. Lewis Sullivan is its highest official.
I think Head Start can be helpful
to us in the whole issue of drug-exposed babies. That will depend, however, on the local Head Start facility having the expertise to really work with these babies so that they can be well served. So it really is more...
Secretary Sullivan says if pilot programs like this succeed, he will consider trying to increase the government's financial support. In the meantime, Dr. Sullivan's department is finishing a report on the impact of drugs. Part of the report focuses on children.
We are not going to really solve the problem of infants born because with drug problems unless we address the problem of pregnant mothers.
So far, in the official multi-billion-dollar federal war on drugs, less than 1% of the money goes for the treatment of women's addiction. And it's anyone's guess as to what fraction of that 1% is available to pregnant women.
We're so far away from a comprehensive program of drug treatment for women in this country who have drug-related problems that it's a joke. I mean, we're lucky if we're serving 1 out of 10.
David Lederman is director of the Child Welfare League of America.
And we're just at the beginning of the process. I mean, unless something dramatically happens to change the current situation, you're going to have more and more young women of childbearing age having a problem, and you're going to have more and more kids who are prenatally exposed.
In fact, in the state of California alone, where there are an estimated 65,000 pregnant drug users, the number of treatment slots available to them is less than 2,000. And that's why people like Dr. Excelana Bean realized that the only way to combat the drug baby epidemic was to get women into drug treatment.
But unfortunately, not a lot of people wanted to come down to South Central Los Angeles and start a bunch of programs to take care of drug-abusing families in South.
So along with her colleagues, Dr. Bean, the physician, became Dr. Bean, the fundraiser. And over the past few years set up 6 programs for women and their families like Project Genesis, an intensive day treatment program. The programs offered child care and transportation, without which most women could not even begin to seek help. But Dr. Bean's programs, like so many in Los Angeles, are only pilot projects.
You demonstrate that the programs are successful. You demonstrate that these are the needs and that this is how you meet the needs. But then after that, there's no funding to continue the program because the goal was to demonstrate the need, not to meet the need. And we're at that particular stage, and so are a whole lot of programs now, at the stage of saying, okay, we have a wonderful program. Everybody agrees it's a wonderful program. But the demonstration money, the pilot money is almost gone. How do we continue to provide the services?
It's been 5 years since this generation of drug babies appeared in hospitals like Martin Luther King in Los Angeles. Those who work with these babies have learned to save their lives and to help them develop properly. But some of the country's public health leaders, and many of those on the front lines, see another way to help, like Dr. Bean, who cares for the babies when they are born, for the children as they grow, and for their mothers when they need to break their addiction and when they are pregnant. At the same time, she also sees that perhaps the best solution will have to begin outside the halls of the hospital.
We somehow have got our priorities wrong in that you're willing to spend $250,000, $500,000 on this baby after it's born, but you wouldn't spend $500 or $600 on it before it was born to try to provide its mother with prenatal care so that it could have been born healthy and not need me. But that's the way our society is.
Secretary of Health and Human Services, Louis Sullivan, is expected to release his report focusing on addicted babies within the next few weeks. However, it is not expected to contain any specific recommendations on how to address the problem. We'll be back in a moment with the AIDS report. In June of 1981, slightly more than a decade ago, the first cases of AIDS in this country were diagnosed. Since then, staffers at the Centers for Disease Control in Atlanta have been keeping track of the number of people with AIDS and of how they contracted the virus, whether through contaminated blood, contaminated intravenous drug needles, or through sex with an infected person. But all along, it's been difficult to count everyone. So recently, the CDC decided that in order to make its count more accurate, the definition of AIDS would have to be expanded. That means in the next year alone, the number of AIDS cases may be 50% higher than under the old definition. Many people hope this will result in increased funding for AIDS research and that more people will qualify for medical benefits. What the numbers omit is that AIDS is always a personal tragedy that affects not only those with AIDS, but also those they leave behind. And that is what our final segment is about one person doing what she can to help her best friend who has AIDS. She happens to be very young, and that best friend happens to be her father. We call this story Gloria. At the north end of Central Park in New York City, there's a neighborhood called Harlem. To find a story of the complexities of urban life or the harsh realities of the streets, you could go to any big city in the country. But to find a story of a simple journey like this one, you have to come here, and you have to meet Gloria. We met her last March. She was 8 years old, and her father, Greg, was 26. Since Gloria was 18 months old, there hasn't been a mother in her life. By now, it seems it has always been just the two of them.
He's my best friend, my buddy. He's everything to me.
It's time to skate. Go roller derby. Go ahead, baby. Be careful. She's the light of my life. You know, every time we're together, you know, the glow in her face is what keeps me going.
They share the details of living.
I do my work for him, and I be good for him.
You know, you do other little things for me. You wash my dishes.
I wash the dishes.
Yeah,
I wash
my dishes.
I take the garbage out.
So that's a little
I put my things away.
And they talk with ease about the kind of love they have for each other.
Bigger than the whole world.
Just actually, she took the words right out my mouth. There's no way to really describe it.
I like this one. I'm cracking up.
Yeah, you are.
Jonathan over here going to...
But you were him anyway. You was loving it. You was like... My best side? I got the best side over here or what?
No.
That's all right.
No.
That's all right, because the daddy's a ham, too. I always ask her...
She is a child, but she knows things most children her age do not have to know.
One day, when I was watching the news, it had some pills about AIDS. And when we came home, he was refilling his medicine, and I saw those pills in there. I said, those look like the ones on TV. He said, you're right, they are. He asked me, what did I have? I said, AIDS. And I said, then I hugged him and I said, I don't want you to die. He's like anybody else. Before he told me, I didn't even know. And I thought all his medicines he was taking is for headaches and rashes. That's what he said he had. That's what I thought his medicine was for. That's why when I go to church, I pray for him. I pray, I say, will you please keep my daddy alive for a long time so he maybe to see me off, maybe if he could see me off to high school.
And not only that, just to be a woman. Yeah, just to be a woman. Just watch you grow. Not only the high school, your life doesn't end after that. You know, so just to see you just be somebody. I want to see you be somebody.
Sometimes she imagines what it would be like if her father was gone.
Yeah, I know it'd be real sad. And every day that I get a chance, I would go visit him at his grave. Bring flowers. I will remember him as if it was yesterday. I remember all the things we did and all the things he gave me and that he taught me.
Two months later, in late spring, Greg became ill and was taken to the hospital. Gloria was left in the care of her grandmother. Sometimes their neighbor Ruth helped out.
That was nice.
Greg's hospital did not allow children to visit the ward where he was being treated. And the summer lengthened.
Every day, I miss him more and more. Because he always stood by me, helped me, and he was my friend and my daddy. I got plenty of pictures of him. But it's just hard, like, listen to the way he's talking, the way he is, like, playful, happy. And my grandma sometimes said it's the end of the road for him. But sometimes, even when I'm at church, I pray for him.
Toward the end of the summer, the doctors decided that Gloria could come to the hospital with her grandmother.
Grandma, she said, this is the way.
This way, oh, back? Okay.
Gloria hadn't seen her father in 2.5 months.
Daddy,